Okay, so today we're gonna switch over more from a neuroscientific point of view into a much more practical view in how to do recordings in the lab. So I've already said that I've brought a few EEG systems, and this morning we're gonna use these EEG systems to do recordings on ourselves. And this afternoon we're gonna look more into designing experiments ourselves. So both this morning and this afternoon, there's going to be a lot of hands-on session in which you're going to try to make an EEG recording work. Depending on how it goes, we're going to continue with some more practical sessions later in this week to record. So today is not the only opportunity to learn the EEG systems. We'll have the next few days as well. But before we start recording, I want to explain how an EEG system works. I want to explain like the things that make EEG systems different, the things that influence how expensive they are, what kind of quality you get, and those type of aspects. So the focus of the lecture this morning is going to be on this device, but I'll also tell a little bit about how the interaction of the stimulus presentation computer with this device works. So I'm also going to talk a little bit about this arrow, because that's what we need this afternoon in order to synchronize the experimental task with the recording of the EEG. So EEG, let me just turn the slides a little bit. So EEG is a voltage difference between electrodes that we place on the scalp, and it's about 1 to 10 microvolts. Depends, of course, on the situation in which you record it. If we look at event-related potentials, we're often interested in differences in two experimental conditions, and such a difference could easily be 1 microvolt or smaller. Whereas if we have intraictal activity, or even if we have a seizure in epilepsy, the voltages can be much larger. But if we're doing research, often we're interested in pretty small voltages that are very difficult to record. So these small voltages on the scalp, they're amplified and then digitized. And this amplification and digitization are important concepts. And the EEG system as a whole is the amplifier and digitizer, which is usually nowadays combined in a single device. So when I started with my PhD, I still had a separate amplifier which was connected to an analog to digital converter box. But nowadays it's usually integrated into a single box, which then connects to the computer. And I would say that the EEG system also comprises the software that goes with it, because it's a software that often allows specific features such as synchronization and those type of things. And we're also going to demonstrate the different softwares that come with the different amplifiers that we've brought. If we think about, so just starting from the perspective of the participant, the first thing that we encounter is the electrode that we place on the scalp. An electrode is not the same as a channel. And this is a confusion that I see with a lot of researchers, is that they see the electrode and the channel as the same. The electrode is a small metal disc that we place on the scalp, whereas the channel is the thing that comes out of the amplifier and that we store on disk. So if you look at this multimeter, which you can use, for example, to check like electrical appliances, we use 2 electrodes to record a potential difference. We have the black wire and we have the red wire. And the difference between the red and the black, so the voltage at the red wire minus the black wire, is the number that is being displayed. So what you can see here is 2 electrodes, 1 channel. The numbers on the screen are the digital representation of the voltage difference. So with EEG, we always talk about voltage difference. We usually record the voltage of all electrodes on the scalp relative to 1 common reference electrode. And this reference electrode therefore influences the difference that we see on all electrodes. If the reference electrode is bad, all channels are going to be bad. So that is why it's important to place the reference on a location where the reference electrode is firmly attached. And very often we would place it, for example, on the bony part behind the ear, which is called the mastoid, or it would place it relatively towards the front on the scalp, like in between where the hair parts, because there's not too much hair here, so we can quite easily get an electrode firmly attached here. An EEG system commonly also has a ground electrode, and the ground electrode is actually not necessary if you have large voltages, but the ground electrode helps to suppress the noise if you're amplifying very small voltages. So that means with a standard clinical system, we would place 21 electrodes on the scalp, but that only gives us 19 channels, because one electrode is the ground, one electrode is the reference. And that also means that in general, with most EEG amplifiers, with n+2 electrodes on the scalp, we record n channels. The reference electrode is important because that influences all the voltages. The ground electrode is in principle something that we can forget during the analysis. It only serves to suppress the noise. But if the ground electrode is not properly attached to the scalp, then the data is going to be noisy. So that's why the ground electrode is also often placed on somewhere on the head where it has good attachment. So in one of the systems that we have, the reference electrode is in one mastoid, the ground electrode is in the other mastoid. Sometimes we place the ground electrode on the forehead. Putting the reference on the forehead is not a good idea, because then you would see eye blinks, because then the reference would be very close to the eyes. But putting the ground on the forehead would also be a perfectly fine idea. If we record larger amplitude signals, such as electrocardiogram from the heart and electromyogram from the muscles, then usually we don't have to worry so much about the noise, because these voltages are much larger. And then often n+1 electrodes are used to record n channels. So that means that if we want to record one channel, we have 2 electrodes. But sometimes we also use 2 times n channels. So if we record EMG, for example, from the left and from the right arm to see whether there's any movements, then often we would use 4 electrodes. We would record the voltage difference on the left arm, and we would record with 2 electrodes, and we would record the voltage difference on the right arm with 2 electrodes. In such a situation, each of the channels has its own reference. So in that case, we have 2 times n the number of electrodes, which means that we just have more electrodes, but we have fewer channels. This also relates to re-referencing, which is a topic that I'm going to discuss tomorrow in the pre-processing of EEG data, because it really depends on the amplifier, whether it allows for bipolar recordings, or whether we use a common reference and record extra channels also with this common reference. This is a very commonly used electrode placement system, and Mikkel already showed some figures yesterday. They were already, and then showed some traces, and then there was something happening in the left hemisphere, and then one of you asked, like, how do you see that it's left? But there's a specific schematic in this placement. Electrodes that are in the middle. Let's first start going from front to the back. So from the front we have F as frontal, and then we have the frontal pole, which is even before that. Then we have the central region, the parietal region, and the occipital region, and then we have the temporal lobes. So that determines the prefix, the letter. And then the second thing in the naming scheme is that we have Z for 0. It's the central electrodes, so all the electrodes along the midline end with Z. And then we have odd numbers on the left and even numbers on the right. And the larger the number, the further towards the side it is. So this is the original 1020 scheme as it was introduced in 1958. Nowadays we're often using this scheme with more electrodes than the 21 which are depicted here. And it's a little bit inconvenient here, this transition from C to T. So nowadays what you see very often is that we don't use the T anymore, but this electrode is called C5 rather than T3, and this electrode is called P5. So that is just something to know, is that T3 and C5 is basically the same location on the scalp. Oh yeah, and The earlobes are called A1 and A2, and the mastoids are called M1 and M2. So this placement scheme is called the 10-20 placement scheme, and that is because it uses distances of 10 or 20% relative to anatomical landmarks. The anatomical landmarks that we're using are different than those that we use in an anatomical MRI or in functional MRI. With functional MRI, we always use landmarks that are inside the brain. So we would often use the anterior and posterior commissura. But if we're recording EEG, we can't see where the brain is. What we can see is, or what we can feel, is how the skull is. So we're using the skull to find these anatomical landmarks. The first landmark to look for is the nasation. The nasation is just like the bridge of the nose, like this small indentation. Then on the left and on the right, we have the preauricular points, which is where the jawbone meets the top half of the skull. So if you put your finger here, and if you move, you're gonna, if you put it too low, it's on the muscle and you feel the muscle moving. If you put it high enough, you can feel where the jawbone connects to the muscle, where the jawbone connects to the skull, and that point is the preauricular point. And actually what we often would do is, if we're preparing this, we would be using a measuring tape. So let me just get a measuring tape out, if they're still here. Oops. And let's see, where's the pencil? I have a measuring tape. So there's also a pencil somewhere here. I don't know where I put it. No, I don't know where I put the pencil. So, but what we often would do is we would use a measuring tape like this, because we need the relative distances. And then we would use a pencil to draw like a small dot on the location that we've just measured out. Because if you feel it, then you put the dot, and then later you can put the measuring tape at that dot. Okay, so I brought a red pencil, but often you can also use like a pencil that you would use for mascara, for example, or anything that just like sticks nicely to the skin, that gives a good contrast. The fourth point that we use is the inion. The inion is this small bump at the back of the skull. So this is where the neck muscles attach. So you have the neck muscles, you have two neck muscles, and there's like this hollow part in between. And in general, the inion is more pronounced with males than with females. So with female participants, it can be more difficult to find this inion. I have quite a easy to find inion. It's just a bump over here. But you should just try with yourself whether you can find this. And in case you cannot find the inion in your participant, you just search for where the muscle ends. So you start low, you move up, and at a certain point you start feeling the skull. That's where the inion is. So it's these 4 points that basically we take as the starting point. So you really go to the participant, you start feeling their skull. You put the dots over here. You don't really need to put a dot here because this point is easy to find. And with the inion, you always have to feel because usually it's covered by hair. And what we then do is we take the measuring tape and we measure how long the distance from the nasation to the inion is. And you divide that by 2. And you measure the distance from the preauricular points. And you divide that by 2. And exactly where these 2 lines cross, that's the midpoint. That's the vertex. And that's the first point where we're going to, so sometimes we put a dot there as well. Usually electrode caps, so if we're placing an electrode cap rather than separate electrodes, electrode caps always have an electrode at that location. So what we might do is we first put on the electrode cap, then we measure, then we feel, then we measure, and then we're going to shift the electrode cap such that the vertex electrode is at the midpoint between left and right and front and back. Okay, so then we continue, and then we're again going to use these measurements that we've taken before, like these numbers. So usually that's around like 40-ish centimeters or so. Then the trick is that we're going to use this number and we're going to take 10 and 20% distances of this. The FP line, so the FP electrodes, are 10% above the Nasion. So if this distance is 40 centimeters, FP1 and FP2 are 4 centimeters up. The same goes like in this direction. So also here, so we have this line connecting FP to C5 to OZ to C6, and that's another line that we then determine. So again, C5 and C6, or T3 and T4, depending on how you call them, they're 10% distance. So then we determine this line. And then we basically start by partitioning this into finer steps where we use 20% distances. So C3 is 20% of this distance. And you can already imagine that you can also place C1. C1 would be in between at 10% distance. Is this clear? Okay, so just go one back. So this placement scheme is important, especially if you work with separate electrodes, with loose electrodes, and I'm going to show those loose electrodes later on as well. But also if you work with a cap, the first thing that you do is try to get the vertex electrodes in between these points. And then depending on how well the cap fits, so we have different size caps for different size heads, so we would usually first start by measuring the head circumference, then we pick the right cap, and then we pull the cap over the head, but you can still stretch the cap a little bit. So also it's important for the placement of the cap that you look that it's symmetric, but also that you pull it right over the head such that these electrodes which are in the cap, that they're also at the 10 and 20% distances. If you fail to do this, then your data is going to be inconsistent over your participants. Because if one participant electrode is here and the other participant electrode is here, then the voltage that we pick up at that electrode is going to be variable between participants, and it's going to make the data, it's going to decrease the chances of you finding a significant effect, and it's going to make the data more difficult to interpret. It's like taking a very blurry photo by moving around. So correct placement of the electrode cap is important, and it is something that you just have to learn by doing it often enough and by practicing. There are other electrode caps, and I will show some of them a little bit later on, but I first want to go to the electrode itself. So, as Mikkel explained yesterday, we have the neuronal activity, so we have the postsynaptic potentials, and that causes, if the neurons are aligned, that causes small currents in the brain, and these currents that are generated in the brain need to pass from the scalp, like through the skull into the scalp, and then from the scalp into the electrodes. The electric current is the displacement of electric charge or charged particles. So if you imagine electricity being generated, electric currents being generated by neuronal activity, then at this interface between the electrodes and the scalp, something needs to happen. On one side of the electrodes, we have the scalp or the skin of the participant, and there electric current is conducted by ions. So basically just dissolved salt. So we have sodium, potassium, chloride, and basically if we have an electric current, so if you have neuronal activity, it's these ions that are moving over the cell membrane, and it's these ions moving through the tissue. On the other side, we have a wire. And in the wire, the charge is conducted by electrons moving. So that means that at this interface between the electrode and the scalp, there needs to be a transition of charge from ions into electrons. And that's what we call the electrolyte. So this electrolyte is this thin layer in between the scalp and the electrodes. And in this layer, ions give off their electrons to the wire or to the electrode, to the metal. So this this means that actually getting a good contact is not so much about getting pressure, but it's about getting electrolyte in between the electrode and the scalp. So there's different ways that we can make this, that we can bridge the gap between the electrode and the scalp. Oops. And I brought different things with me. I'm not going to show all of them right now, but you can have a look at them later, and you can also feel them later. The first method that is especially used if you use separate electrodes is use electrode paste, and that is used with cup electrodes. Electrode paste is really thick. Then we have single-use adhesive electrodes that we stick on, and we especially use them for EMG, for ECG. Sometimes we place them around the eyes, so you can easily stick them on. Then we have electrode gel. Electrode gel is thinner, and we typically use a syringe to place it, to squirt a little bit into the electrode. Yesterday we already discussed that some EEG systems use salt water sponges. So salt water also has ions, and basically the idea of all of these things is that they have ions, so they all have salt in them. So salt water with sponge electrodes is also a technique that is now getting more common. There's also other types of electrodes which are not necessarily different. So one of the electrode types is bridge electrodes, and I will show them later. Then we have dry electrodes and we have active electrodes. There are also some type of electrodes that we don't really consider for EEG. So there's needle electrodes. So in an intensive care unit, or like in an ambulance, if you really have to, like if a patient is really extremely affected and you have to do very quick recordings, they just stick a needle in. There's no EEG preparation, you just stick the needle in, it has good contact. Of course it's painful, but at that moment there's more serious things to consider. And then you have intracranial electrodes, which we use like invasively, for example, for studying where in the brain the epileptic focus is for resective surgery. These are cup electrodes. So cup electrodes are often made of copper with a gold plating. Why is this? It has a little bit of a life of itself. So cup electrodes can also be made of tin. Nowadays that's hardly ever used anymore, but in the past tin was a common electrode, or silver chloride. And I'm going to come back to the silver chloride because that's nowadays the most used as a electrode. These cup electrodes, they have like a small hole. They're like this big. I will show them later. Or you can look at them later. And on the other side, they have a special type of connectors, which you see with a lot of EEG systems. Those are touch-proof connectors. They look like this. And these touch-proof connectors are pretty much like the standard for connecting electrodes to an EEG or an EXG amplifier. And they have the female connector on the lead, so they have the hole on the lead, and they have a pin on the amplifier. To use cup electrodes, you take a jar of, it's a stupid thing. I think I need a new battery for this one, so if someone could find me a battery. If you could find like a small AAA battery for me, yeah. So cup electrodes are used with paste, and the paste is either in a tube like this or in a jar like this, and this paste is pretty sticky. So what we do is we apply a little bit of paste, or we scoop a little bit of paste, and then we press it between the hair on the scalp, and then it more or less sticks. And in order to improve the stickiness, we can use gauze pads, and then you can just like put a small piece of tape over it on the forehead, or in between the hair. We sometimes use gauze, and then we use collodion. Collodion is a special type of glue, and sometimes we'll just like use the hair, So we basically take the electrode and then we fold the hair over the electrode. We fold the hair from the other side and then we glue the hair. And then afterwards you need acetone to get the hair loose again. But the advantage is that it really sticks well. And that is especially important if you do long recordings in a clinical population. The paste stays well for a very long time, so you can easily do like a recording for the whole night. And by gluing the hair over it or by gluing a piece of gauze over it, the electrode is going to stay stable, it's going to stay in place, also if you pull the wires a little bit. The second type of electrodes are, not these ones, but these ones, are single-use adhesive electrodes. So they're basically stickers. You peel the surface, you peel the sticky side off, you get this, and they always come with this knob, which is a little bit similar to the ones that you would find on clothing. And they come with these electrodes, and you basically click them on. They're really easy to use because they're very fast to apply, but of course they're not really compatible with hair. So we'd use them on the bald spots. So for example, behind the ears would be good, around the eyes would be good, or if you record EMG or ECG activity. The third type of electrodes, which I consider like the normal electrodes, because like those are mostly used in EEG labs for research, are sintered silver chloride electrodes. So they're often ring-shaped, as you see there in the upper right corner, or sometimes there's like a small pin, and they consist of silver chloride. So silver is a metal, silver chloride is a salt, and that is then like ground and then squeezed together to make a small pellet. And the advantage of this pellet is that it has a very good interface with the salt electrolyte that you put in between. So sintered silver chloride electrodes are the most stable electrodes. They cause the least artifacts if there are small movements. So what we do is we don't place these electrodes directly on the scalp, or actually also the other electrodes, so the cup electrodes, they're not directly on the scalp, but they're like floating on the paste. With silver electrodes, often we just put them on top of the hair. So they can be like a centimeter away from the scalp. And then we use a syringe with a blunt needle, or like one of these that sometimes like some people like to use. And then we just squirt a little bit of gel. And with this gel, we're making a bridge from the scalp to the electrode. So we're basically filling the gap between the scalp and the electrode. And different systems are in use. For example, these ones, they have relatively large holes. And the advantage of these relatively large holes is that we can use a Q-tip. So rather than using a syringe, we can put a little bit of gel on a Q-tip, and we can put the Q-tip in the hole and turn the Q-tip a little bit. And one of the things that some companies then do is that rather than just providing gel, they provide an abrasive gel. It's a little bit like scrub cream. So if you put a scrub cream with a salt in it, if you put that on a Q-tip and then you turn, you're abrading the scalp a little bit. So the scalp gets a little bit cleaner underneath the electrodes, and that improves the impedance. If the hole is very small, so if you cannot fit a Q-tip through, well, we have blunt needles, but the blunt needles still allow you for scratching a little bit. So that is something where you really have to develop your skills and ask your participants what they feel. So I always first show them the needle is really blunt, so I just by poking myself, so I'm not going to puncture you. Actually, with children, we try to avoid them seeing the needle. So we basically would just approach. So we're not going to tell that we're going to use a needle. We're just going to approach them from the back. There's no mirror. We would sometimes block their eyes so that we basically. So if this is the syringe, we would approach from the back. We would block their eyes and would basically do it like this, because kids can be really scared of needles. With adults, we just tell them that, the needle is not going to puncture your skin. But what you can do with a needle is you can basically push the hair aside and you can scratch the skin a little bit. So if you have an electrode for which the resistance or the impedance, as we call it, is still not good, so that is a feature that we see in the software. There's like not all amplifiers have this, but if the signal on an amplifier on one electrode is not good, we just poke with the electrode and we turn it a little bit. And depending where you are on the scalp, this can hurt. So it's important always to ask the participant to tell or to raise their hand if it hurts. I know for me, it especially hurts over here. So this is like more a sensitive spot. Over here, it's usually fine. So, but that allows you to scratch the skin a little bit, which has the same effect as using this abrasive electrode gel. Okay, so then going towards the more friendly electrode applications. And I would say for research, being friendly to the participants is nice, but getting good quality data is also important. So this is where I'm not really sure how I think about this. We use them for some studies, but we don't use them for other studies because the signal quality with these is a little bit less. So these are sponge electrodes, and the idea of a sponge electrode is still that it has a sintered silver chloride pellet or ring, but rather than putting gel in between the electrode and the scalp, we put salt water, and the salt water is kept in place by the sponge. So here you can very clearly see one of these sponges sticking out, and then depending on the manufacturer, we have the sponges like more integrated into a cup, which prevents the salt water from leaking towards the sides. Because that's one of the problems that we have with these electrodes, is that the salt water distributes itself over the scalp. And if the salt water connects to electrodes, then you get the voltage between these two electrodes cannot be distinguished anymore. It's just like, it's like short-circuiting an electrical appliance. And that's not good. So with salt water-based electrodes, the challenge is really to get enough salt so that it works, enough salt water so that it works, but not so much that you start getting these bridges and these short-circuiting. With these sponge electrodes, it is really crucial that the sponge touches the scalp. And EGI, which is like one of the companies that pioneered the use of these sponge electrodes, for a long time they had a patent on this as well, which prevented other companies from using them, has also made pedestals specifically for African hair. So these pedestals are longer, so you can wiggle them between like a thicker amount of hair, whereas these are the normal ones. So I said that EGI, Electrode Geodesics Incorporated, like an American company, for a very long time had a unique patent on these electrodes. So they were the only ones making them. But this patent ran out a few years ago, and now a lot of companies are making them. So this is the R-net, this is from Brain Products, and this is the net that I showed you yesterday. We're using them with the children in our baby lab. And this is basically how you apply it. So you first put it in a bucket of salt water, then you take it out, you dry it a little bit so that it doesn't drip anymore, and then you just put it on the participants, and then you slide it, again using the measuring tape to get the electrodes in the right position. With the normal silver chloride electrodes, if the impedance is still not good, if the signal quality is still not good, we can apply a little bit of extra gel or do a little bit of extra turning with the syringe. Here what we can do is we can wiggle the electrode a little bit so that to make sure that the sponge touches the scalp, or we can add a little bit of salt. So we usually have a syringe with salt water, and then we can just like drip a little bit of extra salt water on the electrode. Bridge electrodes are actually a very old-fashioned version of these sponge electrodes. So bridge electrodes are used in a clinical setting. I'm not sure whether they're still used a lot. I'm not working in a clinical setting. Bridge electrodes work by placing a cap with rubber bands, or actually it's like so just some rubber bands over the scalp. And these, basically you can adjust them, and these already provide the 10, the 20, the 20% distances. And then the bridge electrode is placed underneath, as you can see here. And these bridge electrodes, they also work with a small piece of gauze, which is made wet. So in a way, they're very similar to the sponge-based caps, except that these are more flexible. I think one of the reasons that these are not really used anymore is that they're rather unstable. You can imagine, like they're relatively high, cables are sticking out like in this direction. So they wobble a bit and they very easily fall off. So this is not something that you would use for a longer recording time, but this is something that you could use for a short recording time. But to be honest, I've never seen anyone use these. And then we have electrodes which are actually which are dry electrodes. And dry electrodes come in different generations. So the first dry electrodes were using gold-plated pins, and so the electrode was basically pushed against the scalp. And to make sure that it's not too painful, the pins had like small springs in them. So there was like basically a spring in contact with the scalp, where the springs would basically ensure that the pressure was large enough, but not too large. So that's what you can see here. But nowadays, all companies have switched over to using conductive polymers, so conductive plastic, and are using plastic pins. Sometimes these plastic pins are covered with silver chloride, like here and here, and sometimes they're not. So sometimes the plastic itself is conductive enough. So the idea is, again, that you have to really wiggle it through the hair so that the pins, they make contact with the scalp. Again, here, the electroconductivity needs to be changed from salt-based, like iron-based conductivity in the brain to electrons in the wire. So in this case, the sweat or the humidity that's in between the electrode and the scalp acts as the electrolyte. So if you have a very dry skin, these electrodes don't work very well. Also, these electrodes are very sensitive for movement of the electrode, because as soon as the electrode moves, the salt that has accumulated under the electrode disappears, and then a new layer of sweat has to appear. So these electrodes are very fast to apply, but they're not so robust. So there have been quite some companies trying to develop these, because they are really the fastest to apply. You just put the cap on, and I have two EEG systems with me that are using these, and you can try them out. But I think that the market for these type of electrodes is primarily for situations where you would have short recordings, or where you would have the participants put on the cap themselves. Like with the syringes, you can imagine that it's very difficult to squirt gel here at the back. Whereas with these electrodes, you can just put on the cap, you wiggle a little bit, and you're done. So these electrodes are used quite a bit in consumer-oriented EEG systems, which are, for example, used for improving meditation, improving mindfulness, those type of commercial applications. I use them for demonstration purposes. So if I go, for example, to a school, like to a high school or primary school, and if I want to show something about EEG, I take a cap like this, because I can very quickly put it on, take it off, put it on the next kid, take it off. Signal quality is not great, but it doesn't leave any residue in the hair, and there's also, like, the cleaning is not really an issue. So that's why I would say these are really useful. But in general, I'm not very enthusiastic about using these for research, because I think that for research we often care about very small voltages, and these very small voltages just require the best electrodes that we can use. So if possible, I would always use the best equipment and the best procedures in the lab, rather than doing something that is fast. Okay, so then something that is not really related to the layer between the electrode and the scalp, but it's still related to the electrodes, are active electrodes. And active electrodes are electrodes where a small amount of electronics is integrated on the electrodes. So in this case, it's pin electrodes. So this is from the biosemi system. So this is a silver chloride pin. It would go in a hole, and you would use gel with these. The active electrode has the advantage that you're amplifying the signal very close to where the signal is coming from, and that means that the signal that goes over the wire is much more robust. So active electrodes make the EEG system less sensitive to head movements, or if the cables are moving, or if there's environmental noise. So here you can see the electrodes that we had, that I also showed you in the videos yesterday. So these are the active electrodes from Brain Products. These are the old ones, these are the new ones. The new ones are very flat. And we use them in the same way as we'd use these ring electrodes. So there's a small hole. We insert a syringe, like with a blunt needle, and we insert a little bit of gel. And since active electrodes amplify the signal, they're less sensitive to movement. So they're also less sensitive to having a poor contact with the scalp. So with active electrodes, the preparation time is usually a bit less than the preparation time that we would use with passive electrodes, with the conventional electrodes. So those are things to consider. Like if you work in a very clean environment where there's no environmental electromagnetic interference, then passive electrodes will work fine. But if there's more electromagnetic interference, or if you want to do the recording slightly faster, then active electrodes can help. Of course, active electrodes do add to the cost of the EEG system. So one of the EEG systems that I've brought has active electrodes. You'll see that the electrodes are slightly larger than the other ones. Okay, so I already explained what the 1020 system is that we use for electrode placement. But for research purposes, we often want to place more than 21 channels. And for this, over the years, multiple extensions have been added to the 1020 system. In a way, very obvious, because we're using distances of 10 and 20%. So the first extension introduced in the 80s was the 1010 standard, which introduces all 10% distances. And actually in 2001, during my PhD, we started working with a 128 channel EEG system. And then I proposed, and that's used a lot, the 10-5 system. So we also used 5% distances. In a way, the placement of the electrodes is obvious. The naming of the electrodes is what is really important, because what you do during practical application of the cap, at a certain point your EEG amplifier, if it has the feature, is going to show the impedances, and then it's going to tell you that the impedance on the electrode, let's say CP5, is not good. And then you have to turn to the participant and you have to find electrode CP5, because that requires a little bit of extra attention. So knowing these names of these electrodes in your cap is important, because that's what you need during the application of the electrodes. So this is the extended 1020 or the 1010 system as we know it. And this is another way of placing electrodes. So this is an equidistant cap. Yesterday I showed in the video that we have different boxes with different caps in our lab. Some people prefer to use these, some people prefer to use these. What you can see with this placement scheme is that the middle line is the longest, whereas if you go towards the front, the line gets shorter and shorter, which means that with equal distances, 10% distances, these electrodes are closer to each other than these ones. And the equidistant caps, they resolve this by placing the electrodes more in a circular arrangement, so the distance between two neighboring electrodes is approximately the same everywhere on the scalp. That is especially obvious here at the front and at the back, because here at the front it gets so dense that we cannot even place so many electrodes. So here all of a sudden we go from having a lot of electrodes, like 9 electrodes in one row, we go to having 5 electrodes in one row, or even having 3 electrodes in one row. The equidistant cap does not suffer from that, so that's why if we don't care so much about the nomenclature, this is a cap that is often used. If we put them on top of each other, you see that some of the electrodes in the 1020 system more or less match, or some of the electrode positions in the 1020 system more or less match with the electrodes in the equidistant cap. So if we then want to report, if we've done the study with the with an equidistant cap, and we want to report electrodes, voltages on electrodes according to the 1020 system, we would use this matching, and we basically say that, for example, on the electrode 18, that is equivalent to FC3. And that would allow people to find where electrode 18 is, because FC3 is a standard name. Another way of placing these electrodes, this is again with an equidistant approximation, is with the EEG DZignet. I already mentioned this. This is the company that for a very long time had the patent on using sponge electrodes. And what they did is they designed a cap that basically has a lot of rubber bands and these sponge-based electrodes in between. The rubber bands are important because you soak the whole thing. So rather than using a cap that is made of fabric, because the fabric would get wet, it uses the rubber bands, and the rubber bands don't get wet. So you can very easily dry it so that only the sponges have the salt water, and then you place it on the participant. So EEGI has made these caps, or these nets as they call them, in 128, or actually in the 64 channel, 128 and a 256 channel version. So a 256 channel amplifier is really expensive. The caps are also pretty expensive. But of course it allows placing a lot of electrodes with a very high density on the scalp. A consequence of using the salt water and having so many channels is that with an EEGI system, it happens quite often that two electrodes that are very close to each other, that they have this bridging due to the salt water. So with the EEGI system, it is more common that you have a lot of bad channels and you cannot basically pay attention to each individual channel. So most people that are using EEGI systems are not using the 256, but are using 128. If you go to the 64, then the disadvantage is that these mushroom-like pedestals, they become unstable. So there's not so many of them, so they tip over. And if they tip over, the sponge doesn't touch the scalp anymore. So this also doesn't really work with too few electrodes. So EEGI has done this mainly for 128, 256, and now more companies are making them, but are trying to make the pedestals with the sponges such that they are like more stable. And you see like a lot of companies now having them. So these are some of the electrode caps that are common. Also using different types of material, and each EEG company has their own style. So this is one from Electrocap International. This is like an old-fashioned cap. It often comes with tin electrodes, which are not so stable. This is a system from Biosemi. So this is a system that I used during my PhD. It's a 128 channel cap, and they have basically small holes, and you stick this needle type. No, it's not really needle. It's more like a pin type electrodes. You plug them in. This is another European company. This is Brain Train. It has sponge electrodes. So they also have a conventional one, but this is a sponge electrode version. And here you see that they've put the sponges in a regular cap. And in this case, you don't soak the whole cap, but you just use a syringe to drip a little bit of water on each of the electrodes. This is just if you have a few electrodes. These are the caps that we used a lot in the past with the ring electrodes. Some companies try to make it flexible so that you can basically have one cap with different electrode arrangements. This is one of the caps that I've brought, except my cap has different electrodes. So this is a cap from GTEC, an Austrian company. This is a cap from A&T. It has passive electrodes, but it has wires that are specially shielded. So each of these caps has their own advantages and disadvantages. And it is actually an important consideration if you buy an EEG system, is that the EEG system often comes with a cap as well. So some companies have better quality caps than others. Some companies have more expensive caps. Some companies have more flexible caps. If you have a cap like this, so in this specific example, the wires are sewn to the cap, which means that if you have if you want to have caps in different head sizes, you also need to get electrodes for each of the caps. That makes it expensive, because the electrodes are actually pretty expensive. If you have a cap like this, the electrodes are sewn into the cap, so there's no wires, so it looks really nice and clean, but also these are also expensive. Whereas if you have a cap like this, you can basically have multiple caps. The caps don't have the electrodes in them. The electrodes are separate, which means that you can have multiple sized caps with one set of electrodes. So these electrodes, it's like I just happen to know, these type of electrodes are about 20 euros a piece. So with a 32 channel cap, that's about 600 euros worth of electrodes. If you have a 64 channel cap, it's like already more than 1,000 euros worth of electrodes. So that then you can imagine that if you need to have 2 or 3 different sizes, you're spending a lot of money on electrodes. Whereas the cap itself is just fabric, it's way cheaper. So that's why in the labs that I showed you yesterday, we have the electrodes separate from the caps. We have different cap sizes, and we have one set of electrodes, and we just slide the electrodes in the cap, which does increase the preparation time, but it reduces the cost for having multiple caps. So these are all important things to consider. So it's an EEG system. It's not only about the amplifier, but it's also about the caps and the electrodes. Any questions about this so far? I'm now going to move over. Yes, let's just, I'll hand you the microphone.
Thank you. I wanted to ask, some of the electrodes cannot move up to 19 channels because like the last one you showed us, the bridge electrode now, can it have up to 19 channels?
I'm not sure with how many channels this is used, but I would say this is often used like in a more acute situation where you want to do a very quick recording. So probably more likely to be used in intensive care units where you just want to quickly get some electrodes in place, for example, to see whether someone who's unconscious, whether they have a seizure or not. And for that, you don't need a lot of electrodes. You just need a few. So I would say that this system is not really designed for high density. It's bulky, but it's relatively quick that you can apply it with a few electrodes.
Okay. Another thing is, can you use the reference electrode and ground electrode and some of these electrodes? I don't think you can apply the ground and reference electrode all the types of electrodes.
That's indeed a good point. So the different EEG systems, they also differ in how they deal with the ground and with the reference electrodes. I'm not sure whether that's visible from this one, but often so for example here you can see that there's two special electrodes behind the ears, or actually in front of the ears, which are like the reference and which could be a ground electrode. With this cap, I think they've cheated a little bit for the photo, like to make a nice photo out of this. This wire, I think, goes back and goes behind the ear. Usually this wire is basically running around it because this cap is using a reference electrode behind the ear. So I think they've just tucked it away to make the photo nice and clean. So this cap clearly has an electrode behind on the mastoid, and that's an electrode that you would use for the reference. If we look at the hardware that I've brought, you will also see that the different hardware systems have made different choices there. What is important is that the ground electrodes only helps to reduce the noise. The reference electrode really influences how to interpret the data. So in the pre-processing of EEG data, what we're going to look at tomorrow, we often re-reference. So we often change the reference so that we can interpret the data more cleanly.
So not necessarily that the ground electrode have to be placed here, because in the EEG eye, where you have 128, and you have multiple electrodes here, so you must not have the ground electrode placed
I've not used the EEG system myself, but if I recall correctly, the EEG system uses one of the electrodes over here as the ground, and it uses CZ as a reference. So the EEG system does not use other electrodes than the ones that are in the cap. But for example, the GTEC system that I've brought, the GTEC Nautilus, that uses two stickers behind the ears for the ground and the reference.
Thank you.
Thank you very much. There are two questions really. Applications in mindfulness.
In wakefulness?
Mindfulness.
Mindfulness.
And then what informed the design of cap electrodes? What anthropometric things?
Yeah. So I think that research applications. Could you get a microphone? So research applications in mindfulness can of course be done in a laboratory environment. And if you have a laboratory environment, then you would have a researcher and a participant. And sometimes you have a research assistant, so there's one or multiple people that can help by putting on the cap. So that means that you can use research quality EEG systems. But if you want to study mindfulness, or if you want to do mindfulness in a home environment, then the requirements for the EEG system are different, because if you have to put on the cap yourself, then you cannot use the same types of caps as that you can use if you have two people. And we're gonna see this in the hands-on as well. So I really have different systems. So one of the systems that I brought, I have two of them, are for self-application. And two of the systems that I've brought are not really for self-application. They require someone to walk around the participant and to use the syringe. So it's not necessarily the mindfulness, but more the setting where it happens that influences which design of the cap would be most optimal. As I was also saying, like with the bridge electrodes, that is optimal if you have to quickly apply a few electrodes, and it has to be done by someone who's not trained in placing these electrodes. With the cup electrodes, you have to measure. So cup electrodes require more skill, they require more training. The caps make it easier, but caps still have to be placed in a consistent manner. So with mindfulness, research into mindfulness, if you really want to know where in the brain certain correlates of mindfulness are, I would say it is important to use the same research quality caps, which are more like the ones that you see here. But that doesn't mean that you cannot use it with a system like this, which has like only a few pre-configured electrodes. It's more like, what do you consider optimal for a certain scenario? And for a home scenario, I would say dry electrodes are really optimal. But for a research scenario where you have a researcher and a research assistant, then you can use something else. So there's not one optimum for, because it really depends on how you're going to implement the system. Also something that I think is relevant, and you're going to see it as well with the systems that I've brought, is that if you do research in a home environment, you often want the amplifier to be battery operated and portable, so that you can move around. Whereas in a laboratory environment, so the videos that I showed yesterday and that are also on the shared folder with the presentations, those videos show that we do the recordings while the participant is sitting in front of a computer, not moving that much. So in our lab, having the systems wireless is not that important. But in a home environment, wireless would be very important.
I was going to say, like the Holter ECG, can be wired to a patient and it can go home.
Yes.
So it can also be applied that way.
No, so most of the systems that I'm showing here are systems that you would use in a laboratory environment for research purposes, so not for clinical purposes. So a Holter EEG is an EEG, is for long-term monitoring of the patient, or typically that is used for patients, where a small, usually something that you would wear on the belt, similar as the microphone that I'm wearing here, so that the patient would walk around and that you could record the EEG over a long amount of time, like 1 or multiple days. So that is typically done with the cup electrodes that are glued in between the hair, because they can stay in the hair for a long time without losing their signal quality. The salt-based electrodes, they dry out. So salt-based electrodes are good for a recording of, say, half an hour up to an hour. The gel electrodes, they don't dry out that fast, but eventually they will also dry out. So the length of the recording is also a consideration. Usually, so I'm saying that we have normal electrodes, but that's normal because in the research that we're doing at our center, in our center, normally we have experimental sessions that last about 1 hour to 1.5 hours. And that's because we're doing a cognitive task, and after 1.5 hours, the participant is really bored with the task. It doesn't want to do the task anymore. So we don't need to have electrodes that stay good for more than 1.5 hours. If we do the baby recordings, the babies are not going to sit still for more than 10 minutes. So that means that we don't need to have electrodes that stay well for more than 10 minutes. So that's why for the baby recordings, the sponge-based electrodes are good. Whereas for adult recordings, I would say, well, they're good for shorter experiments, but not for the longer experiments. I know of people that have done, that have used this system. Oh, actually, the presentation disappeared. I know of people that have used this system for sleep recordings. That was not very successful because the electrodes simply dry out. So in the middle of the night, the participant needs to be woken up, or at least the participant needs to be interfered with to just apply a little bit of salt water to each of the electrodes. So Holter EEG systems are really designed for the purpose of long-term monitoring, but are not really designed for doing recordings in a clinical environment where we do an experiment where the participant is interacting with the computer. Holter is more for epilepsy monitoring. Yeah.
Correctly, two things. It's good inside this is 120 to 56. What are the chances of having artifacts when recording? Because it looks more sensitive. And the other is, in my practical area, we try to use tape like 20 in ICU artifacts are so high. What is your point?
So with this system, I would say the chance of having artifacts is 100%. You're always going to have artifacts with this system. You're always going to have the situation that the electrodes, that some electrodes are not going to have good contact with the scalp. And you're always going to have the situation that some of the electrodes are going to move a little bit during the experiment because there's so many electrodes, and the electrodes are basically just like hovering a little bit over the participant's scalp. So this system, there's always artifacts. But since you have so many channels, it's not so bad if you lose a few channels that have artifacts. Whereas if you have fewer channels, if you lose a channel that has artifacts, that affects your recording, your later analysis much more. So as such, there's a trade-off between the number of channels that you have and the number of artifactual channels that you can afford. But ICA, one of the cleaning techniques that is used for cleaning EEG data, requires more care in removing movement artifacts with these electrode caps than with some of the other electrode caps. So during the analysis, which we're going to deal with tomorrow, it is also important that you know what type of electrode cap was used, because that is going to influence the type of artifacts, and it's going to influence how you have to pre-process the data. Yeah?
Okay, so my question is on ECG. Yesterday when we saw the speed page, I realized there was a sheet from EEG, the ECG attached to it at the bottom part of it. So I want to know, are there specific electrodes that record the heart activities attached to the ECG sheet?
We would typically use these electrodes to record ECG. So on the chest, if you just, so at this moment with me would be pretty difficult because I'm sweating and these electrodes would fall off again. But if you're in a cool enough environment, you just clean the skin a little bit, you stick an electrode on and it sticks well. And this is a very fast application technique. I'm not a cardiologist, so I would typically not really study the ECG. I would only care whether there is heart activity that is correlated with the task. So I would, for example, use the ECG to monitor the heart rate. For clinical ECG, they would place like an Eindhoven montage with 12, I think it's with 12 electrodes over the chest, to also study where specifically on the heart an infarct, for example, takes place, or where, like those type of things. So that is a level of detail that I would not care about as a neuroscientist. So for me, I would typically place one electrode here, and then I can record the heart activity just well. And then I would use that to help to clean the EEG data. or to see whether there's a relation between the task and the heart rate of the participant. For example, that if a task is very difficult, the heart rate might go up, and that would be a potential confound that you would want to know about. Yeah? Just a sec, the microphone is coming your way.
Okay, you're talking about feeling here.
Sorry.
With gel.
Yeah, so this is with the gel, yes.
So you don't know the distance, what the distance from the ear to the scalp? Is it a particular distance?
It doesn't really matter. The gel is, it matters a little bit. It depends on the type of gel. But I said I've only recorded from an African participant once. The African participant had like a very curly, fluffy hairstyle. I don't know how you call that, but like, it's in the Netherlands we call that an afro. So what I did was actually, it was a young girl, I think 12, but I took the largest adult cap that I had and I just placed it over the hair, which meant that the distance between the electrode and the scalp was like this. And then using the syringe with the blunt needle, I went in and I just squeezed a little bit of gel out all the way towards the electrode. So basically just making a long, slimy thread through the hair to the electrode. And that worked actually quite well. So most of the electrodes had a good connection. But of course, this is more difficult to do than if the electrode is closer to the scalp, because then you can just like draw a smaller piece. But it's not that the gel has to sit like close to the scalp as we have with the paste. With the paste, we really have like a lump of paste on the scalp. With the gel, we can bridge quite a long distance. The disadvantage is if you start moving, then of course the gel also starts distributing and it becomes a mess. So it's not easy, but the electrode really does not have to be on the scalp. If you use the salt water based electrodes, it's the salt water that needs to touch the scalp, and the only way that you can get the salt water to touch the scalp is by having the sponge touch the scalp. So that's why I would say that I suspect, but I don't have the hands-on experience, but I suspect that these type of electrodes and with gel work with the most diverse types of hair, because of the ability of bridging the distance between the scalp and the electrodes using the syringe by just squeezing while you're retracting the syringe. And this is something that we can practice after the coffee break by just trying out how that works. Just wait for the microphone.
I'm sorry to bring you back, but as an African research physician, it's important that we address the question. The second part of my question had to do with the design of the caps, particularly the cap electrodes. Are they based on parameters on Caucasian studies? Have you taken African studies of craniofacial parameters into consideration?
So about the size of the caps, you mean?
Yes, it's design, because
so I'm not sure whether there's specifically African design caps. I'm also not really sure whether there's differences in head dimensions between Africans and Europeans. I know that there are special caps for Asian people. Asian people tend to have a slightly rounder head. So the European style caps or the Caucasian caps don't fit the Asian heads so well. So for Asian participants or in labs where, like in Asian labs or in labs where there's a lot of Asian participants, you would have the Caucasian caps and you would have the Asian caps. I have not heard about like systematic head size variations in African participants relative to Caucasian European participants. I do know that for baby recordings, the fit of the cap to the baby's head is also like often more problematic because babies' heads are often more variable in their shape. So that means that baby caps often fit relatively poorly. But if I look at you, I don't really see that your anatomy of the skull would be that different, like from the upper part of the skull, would be that different from the European. Of course, facial characteristics are different, but that's not relevant for the placement of the EEG cap.
I think it's better to establish that. So would you mind if it came upon us this way to go into those areas so we can feel the knowledge gap, even if it's not almighty, but subtle differences have been observed to be statistically significant.
Yeah.
Yes.
Yeah.
So, would you mind if we asked, to be assisted to go into those areas of inquiry?
Yes, I think that would be really interesting to also use this week to discuss this further. If now thinking about like head shapes,
Yes.
I think the most reliable way to assess the head shape is by taking an anatomical MRI.
Sorry?
Because by taking an anatomical MRI scan. Because with an anatomical MRI scan, you really see the scalp really well, and you can measure, you can offline, you can measure and determine the head size in all the different directions. The thing that we're missing in an anatomical MRI is the hair, because it doesn't show. And to be honest, I think the biggest challenge that we would have with African participants is not so much with the head size, but it's with the hair. It's like, and how do we accommodate the African hair, and especially African hair from female participants, in the caps that we have. Like, for example, you have a lot of hair. So that's going to be challenging. Like, you're not going to, if I measure your head circumference, I would choose a cap. But if I look at your hair, I know that I should better use a larger cap. Because otherwise, your hair is not going to fit underneath. And it's those type of things that I think are important to discuss as well. The European style of hair is very straight. So it's relatively, so even participants that have long hair or that have a lot of hair, it's relatively easy to fit it under the cap. But if you have curly hair, you just need a bigger cap. So I've brought 6 different caps, six different EEG caps. Yeah. No, actually more. I brought in total like 10 EEG caps. And it will be interesting to see how those caps fit on the participants here and how they fit, for example, with the hair. Because like the standard procedure would be to measure, then to pick the cap to put it on. But I think it would be interesting to see how that actually fits on the participants with more hair. And then even without applying the gel, that would already be an interesting experiment.
So based on the hair texture, what we use in our lab is actually the bridge cap.
You use bridge electrodes?
We use bridge because it accommodates whatever hairstyle.
Yeah, I can imagine,
person is
yes.
coming with.
Yeah.
And then because you have the retractable rubbers, you can either expand or reduce.
Uh-huh.
So that works for us.
That's interesting to hear, yeah. Of course, with bridge electrode, it is more difficult to place a lot of them. So how many bridge electrodes are you using?
16 channel.
16 channels.
Yes.
Oh, yeah. Yes, yeah. So that means that spatially you're not getting so much information. But that, of course, depends on the research question, whether you need so many channels or whether you can work with fewer channels.
And for most times, it's actually for shorter tests. not
Yeah.
for long ones.
Yeah. It's interesting. There was one more question there in the back.
Okay, thank you. I'm sorry to be back again. First, my first observation is we've not talked about the EEG video telemetry. And the second question is, if I were looking at developing a portable EEG device for a patient or an epileptic patient, would I still use any of these EEG caps to design a portable device for the patient, or I will have to modify some of the caps, increasing some of the electrodes or removing some of the electrodes in order to achieve this?
So I have not talked about the same questions with the Holter system. Yesterday I introduced that we're mainly going to discuss EEG for research purposes, which also means EEG typically in a well-controlled environment of a laboratory. So using an EEG system at home or doing remote measurements, I clearly see the usefulness and the need for that, especially for clinical applications, where, for example, you would want to be able to have an EEG system somewhere in the small village without the expertise in the small village, where you would want to have a neurologist look along with the EEG on distance. And I think for those type of applications, you would indeed have other requirements than the requirements that we have in a more controlled lab environment. Wireless might not be the most important, but being able to transmit the data over a long distance, that would be important. And I know that EEG companies have worked on that. It's a field of clinical research that I'm not working in. So I don't know what is done there. But I do think that an important consideration there as well is that if the expert that needs to interpret the EEG is at a distance, then you also don't have the expertise to apply the cap. And that makes it a little bit similar to having an EEG system at home, where just a regular person puts on the EEG cap. So in laboratory environments, in the laboratory environment where I work, so the labs that I showed yesterday on the video, we always have trained staff to apply the cap. But I think for like remote monitoring of EEG, an important consideration would be how do you get the electrodes correctly in place, and also how do you make sure that the electrode system is robust? Because what we're going to see if we're going to do if you're going to try out the EEG systems, you're going to see noise. And then you have to look at the noise, and based on the noise, you have to make a decision what you're going to do with the electrode that has the noise. Are you going to wiggle it a little bit? Are you going to put a little bit of extra gel? Try to adjust the cap so that it's a little bit tighter. And that expertise might not be available or might be less available if you're doing remote monitoring with an EEG system. So I think that it's not so much the cap, but it's more the electrodes and the robustness of the electrodes that would be relevant. With I would still say this is pretty robust. This is not too difficult to explain. If I think about like this system, if I would have to explain my mother how to put this on, like just like as a person who doesn't know anything about EEG and stuff, I think it would be likely that she would either use too much salt water or too little. And especially I would be afraid that she would be using too much salt water, because if you tell salt water, let's overdo it. And if you use too much salt water, the signal quality is going to go down because you're short-circuiting all the electrodes. So as such, for this system, although it can be applied faster, I think by applying this system by untrained people, it's going to be less robust. I think the bridge electrodes might actually be electrodes that would be quite suited for short-term recordings at a distance, because you can clearly see how they work. You just have to wiggle the electrode, you have to push it through the skin, and there's a little bit of salt water on the electrode itself. But I also think that's an important consideration. Like, do you need a lot of electrodes or do you need a few? And I would imagine that for clinical applications with remote monitoring, you would not necessarily need a lot of electrodes, which would again be an argument for using bridge electrodes like these. But it is something that I don't have hands-on experience with. And also, for example, in how to store the signal and how to remotely transmit the signal, it's not something that I have experience with. I can show the features of one of the amplifiers that we have. I will show, because that amplifier can run in different modes. So it can also run battery operated, and it has internal storage so that you can attach it to your belt or in a backpack in a similar way as I'm wearing this one now. And I think that would be relevant both for a Holter type system or for a remote monitoring system, so that if the wireless connection gets lost shortly, as happens here quite a bit, you would still want to store the data. So I think that for a remote monitoring, I think it would also be better to do the recording while the neurologist is looking along. But if the recording then subsequently gets disrupted because of Wi-Fi or mobile connection issues, that you would still download the whole recording afterwards and then review it properly by going back and forth in the data. That's what a neurologist would do anyway. So I think you need a combination, but it's also about the procedures then. It's not only about the EEG system. Yeah? So there is more that I had planned to tell about how an EEG system works, but I think it would be good, given that you've already been listening for quite some time. They would first have a break. So I'm wondering whether there's already coffee, possibly outside.